And so I have the pleasure of introducing the last speaker of the day. Super exciting and rapidly emerging, I would say, topic. So this is Dr. Timothy Wilkin coming to us from University of California, San Diego for the past year plus now. I think many of us knew him from his time at Weill Cornell. And obviously is a leader in the field, has been a leader in many clinical trials, national and international, particularly in the ACTG space, currently the chair of the ART TSG. Welcome, Dr. Wilkin. I will hand it over to you.
Great. Can you hear me?
Yes, we can.
Okay, great. Thank you, Susanna. I'm happy to be here. Sorry, let me just fix my screen a little bit. Okay. Here are my disclosures. Okay, sorry, and here are the learning objectives. We're going to talk about the epidemiology of some of the HPV-associated cancers in people with HIV. We'll spend some time talking about anal cancer screening and describe some different approaches to that. And we'll finish up with some additional information about vaccination, including some population-level impact of vaccination, some long-term follow-up of people who had received vaccination for prevention of anal cancer, and some other topics. Okay, so a quick primer on HPV. Many of the HPV-associated cancers, anal cancer, cervical cancer, kind of follow this pattern. So you have the squamous epithelial cells, and it's really these basal membrane cells that are the target for HPV. So we think that HPV infects these cells by these kind of micro abrasions in the epithelium. They bind to the basal cell, and over time they enter the cell. And if there's the right amount of DNA damage, you can start to have dysplasia and eventually invasive cancer. So when we think about how we intervene upon this, the first thing that we should always talk about is vaccination. So if you have vaccines that generate long-lasting levels of antibodies, these antibodies can bind the HPV and prevent the entry into the basal epithelial cells, preventing all of what we're going to talk about today. But there are other things, especially when we talk about people living with HIV, that affect this process. So kind of the signature issue with HIV is this impact on cellular immunity. And that type of immunity is really critical for clearing this persistent HPV infection. When people start antiretroviral therapy, that improves this cellular immunity and can lessen some of the impact of HPV disease, but doesn't really bring it back to that of people without HIV. And then there's other risk factors for HPV-associated cancer, such as smoking, which can increase this process. So when we think about HPV, the vast majority of HPV infections come and go. We don't ever know anything about them. They don't ever cause any problems. It's really the minority of them that can persist. And it's persistent infection that lasts for 6, 12 months, years, that really is what is concerning for the development of cancer. So in these areas of HPV persistence, there can be the accumulation of DNA damage, increasing oncogenesis and the development of pre-malignant lesions. And when these pre-malignant lesions are not treated over time, they progress to invasive cancer. So this is the pathogenesis for cervical, anal cancer, probably penile, vaginal, vulvar cancer. We'll talk a little bit about oropharyngeal cancer later, but it's a bit different for that cancer because we don't really understand what the pre-malignant lesion is, and we can't really screen and find the pre-malignant lesion. So just a little caveat there. So when we talk about the lifetime risk of HPV infection, it's just basically everywhere. So the more you search for human papillomavirus, the more you find. And so you see really high rates of HPV infection over someone's lifetime. What's a little bit, data's a little less clear is what the prevalence of HPV is using a clinically relevant test. So if you use a laboratory PCR-based test, you can find HPV in almost anyone who's been sexually active. But the the lifetime risk of a clinically relevant or an HPV infection detected on a clinical assay is a little unclear. We know that men who have sex with men have a much higher rate of HPV infection than other groups. And when we think about the cancers, there's about 40,000 cancers per year caused by HPV in the US, and that does seem to be increasing. Worldwide, cervical cancer causes about over 300,000 cervical cancer deaths each year, mostly concentrated in women in low and middle income countries. And 85% of all cervical cancer cases occur in these low resource settings, especially where they have not been able to implement cervical cancer screening. And I should have included this on here, but HPV is responsible for 5% of human cancers, so really a major oncogenic agent around the world. So just focusing again on US trends, cervical cancer rates continue to decline. I think this is really just a major public health success story in areas of the country and in populations with access to cervical cancer screening. Really, you can prevent the vast majority of cervical cancer cases. And now with HPV vaccination, should we ever achieve widespread vaccination, we can see the elimination of cervical cancer as a public health problem in the US. Sorry. However, anal cancer does seem to be increasing. So it's important to remember that for anal cancer across the US, it's more common in women than in men. For those of us who care for people with HIV, we see a different story because we care for a lot of men who have sex with men, and they are at much higher risk of anal cancers we've seen. Overall, anal cancer is pretty rare in the general population, and our biggest hope to really prevent anal cancer in that group is, again, widespread HPV vaccination. So something that's maybe you're a little less familiar with is oropharyngeal cancer. So oropharyngeal cancer is kind of divided into two groups. There's HPV associated, and the rest is more tobacco alcohol associated. In areas of the world that have good tobacco cessation programs or public health approaches to reduce tobacco consumption, we see that HPV associated oropharyngeal cancers is more common than tobacco associated. So in the US, about 60 to 70% of oropharyngeal cancer is caused by HPV. And it's actually more common. HPV-associated oropharyngeal cancer is more common than cervical cancer and has been for over 15 years. So when we talk about the public health impact, it's really HPV-associated oropharyngeal cancer is, really the major one for the US. And as we know, oropharyngeal cancer is about 5 times more likely to develop in men than in women. So sex disparity here. And we think this is because women generally acquire HPV through vaginal sex, and that typically develops an antibody response. And it's thought that that antibody response helps to protect against oropharyngeal cancer or oropharyngeal infection with HPV. When we talk about HIV infection, sorry, let me just go back and make one prior point here. The key, we'll talk about HPV vaccination a little bit later, but one key fact, we don't have really effective screening methods for oropharyngeal cancer. There's no recommendation for oral HPV testing or even specific examinations to find precancers because we don't really have a precancer lesion for oropharyngeal cancer. And there's some work on diagnosing oropharyngeal cancer earlier where it's much more treatable. But essentially, a lot of oropharyngeal cancer is diagnosed at later stages. It can be very treatable, but it's a very morbid treatment. It can be disfiguring, and certainly recurrent cancers, and the death rate from oropharyngeal cancer is quite high. So it's really a cancer that we need an effective prevention method. And as we'll talk about a little bit later, vaccination seems to hold the most promise. When we talk about HIV and HPV-related malignancy, HIV absolutely increases the risk of HPV-related malignancies. So early on, cervical cancer, invasive cervical cancer was listed as an AIDS-defining illness, yet anal cancer is not. So it's that distinction is probably not so helpful anymore, but it seems on the whole, cervical cancer is about 6 times more common in women with HIV compared to women without HIV. Anal cancer is up to 20 times more common and up to 40 times more common in men who have sex with men with HIV. So one of the challenges with understanding that is that most of that increased elevation is because of sexual history and the types of sexual activity that people with HIV have generally engaged in. So if you compare men with HIV who have sex with other men compared to men without HIV who have sex with other men, it's probably like cervical cancer, maybe 3 times higher, something like that. And then for oropharyngeal cancer, again, 2 to 3 times higher among people with HIV. When we look at other factors specific to HIV that seem to be important, really the one that stands out, the two that stand out the most are the history of low CD4 naders and prior history of AIDS. So that advanced immune suppression really dramatically increases the risk of cancer. And even when people are on antiretroviral therapy and that immune suppression has been restored, there still seems to be this persistent elevated risk of invasive cancer that those individuals have. And then the other thing that we can also control is smoking. So this tobacco status or ongoing tobacco use seems to increase the risk of developing invasive cancer. So certainly tobacco cessation strategies, should be pursued as well. So this is a complicated diagram of different rates of invasive anal cancer, but I want to walk you through a few different things. Here is our historic cervical cancer rate. So this is the rate of cervical cancer prior to any kind of effective public health screening, about 25 per 100,000 patient years. This is our current cervical cancer risk. So we've been able to reduce that by 2/3 in this country. So the target, when we talk about who we would screen, who would we offer anal cancer screening, several groups have proposed using a cutoff of populations that have a 10-fold elevated risk of anal cancer. And that's what this line shows. So when we start talking about what some of these populations are, here is men who have sex with men. These were those with HIV, just at different ages, all with markedly elevated rates of invasive anal cancer. Here at the bottom, we see men without HIV who have sex with men, and also those elevated risks, but not nearly as dramatic as those with HIV. When we talk about other men with HIV over the age of 30 to 45, they seem to have these markedly elevated risk of anal cancer. But in the general population of men without HIV, men who do not have a history of sex with other men, you see very low rates that would not merit anal cancer screening. For women with HIV, pay attention to this one. It's really those with that have the age over 45 that seem to have this markedly increased risk of invasive anal cancer that would merit screening. Other populations that we haven't really talked and there's less data about, but those who've had women that have had a history of vulvar cancer, vulvar precancer, those with immune suppression, so solid organ transplants that are like 10 years out, there's these subgroups that seem to have these elevated risk of an anal cancer. So in the future, there may be more recommendations to screen the broader populations or targeted screening of broader populations that have this elevated risk of invasive cancer. Okay. Sorry, we talked about that. And then putting some of these cancer rates into perspective, when we talk about men who have sex with men who are living with HIV, these rates of anal cancer are on par with rates of breast cancer in women, prostate cancer in men, higher than lung cancer. So these are really elevated rates of cancer and ones that would merit screening approaches. Okay. We talked about some of this, but this really applies to anal cancer and cervical cancer. So when we compare people with HIV compared to those without HIV, there does seem to be a higher risk of HPV acquisition. And we don't really know whether they're just people are generally exposed to more HPV, or if they are exposed, they're just more likely to persist, and therefore you're more likely to diagnose it. But it is clear that they are less likely to clear HPV. And all of this leads to a higher incidence of these pre-malignant lesions and a reduced chance of these pre-malignant lesions actually regressing back to normal. However, when we start people on effective antiretroviral therapy, we do find that there's overall a lower risk of HPV and a lower risk of progression to HSIL compared to those not on effective ART. So one of the major impacts that we've made against HPV-related cancer is really the effort to diagnose HIV earlier, to institute treatment for everyone when they're diagnosed. And that really prevents a lot of the severe immune suppression that dramatically increases the risk of cancer. So that's been a big approach and why we've seen some of the rates of invasive cancer decline. Talking about invasive anal cancer, the screening test we'll talk about briefly, but that's pretty simple to implement. Really, the challenging part of anal cancer screening is that once you've screened somebody and they have a positive screening test and they need to move on to a diagnostic evaluation, that can be incredibly challenging to find. And so that procedure is high resolution anoscopy. So this is a procedure that's analogous to cervical colposcopy. So this is inserting an anoscope into the anus, putting in acetic acid or white vinegar to make areas of HPV damage show up. On the 12 o'clock here, you can see the kind of whiter area with these abnormal blood vessels. So these are areas that we would look for in biopsy to diagnose, and areas that we would then go back and seek once we have a diagnosis of precancer to treat and ablate to prevent them from turning into cancer. So another picture here, a little bit easier to see. Again, at 12 o'clock, you can see the yellow area. This is after application of iodine. And so normal squamous epithelium takes up the iodine, looks brown, but the areas with precancer do not, and they look yellow. So again, that would be an area to biopsy. And then when we go back and treat, it's actually a simple office-based treatment. We go and find the area, inject it with an anesthetic to numb it, and then we can use a machine called a bifurcator to kind of ablate this epithelium to prevent it from turning into cancer. So the IANS, the International Anal Neoplasia Society, is the group that's sort of taken the lead on the training activities. So it's a pretty well-developed pathway of how someone gets trained in this and becomes proficient. In addition, we can diagnose invasive cancer, hopefully at an earlier stage. You can see on the left and on the right, those even without anoscopy, you can see HPV damage or high-grade lesions around the anus. This looks very similar to vulvar HSIL. So these are areas that you might notice when you're doing rectal exams. These areas like this kind of hyperpigmented plaque should be referred for evaluation and treatment. So why am I making the assertion that you should treat these areas? So this is all based on the ANCHOR study, which screened about 10,000 people to diagnose 4,500 or so individuals living with HIV with anal HSIL, so a huge study. And so the design was pretty straightforward. Half of those people were treated for their HSIL lesions and received treatments multiple times in some cases, whereas the other half was just watched without treatment and just semi-annual evaluations. And so overall, the strategy of treating the anal HSIL led to a 57% reduction in the incidence of invasive anal cancer. But one thing I want to draw your attention to is that the rates of anal cancer actually in both groups were still markedly elevated So 400 per 100,000 patient years, as opposed to around 175 per 100,000 patient years. So very high rates of anal cancer in this group, even among those that had received treatment. And so this difference in risk seemed to be pretty steady over time, and really between 1.5% to 2% of the group that was just monitored without treatment developed cancer by 4 years. So really high rates of cancer. So some of the controversies that remain in anal cancer screening, there's a need to improve our HSIL treatment. So we need, more pathways for people to get trained, larger numbers of providers. But we definitely need novel or adjunctive therapies that really improve our treatments. And there's not widespread access to quality HRA. So ideally, we could come up with screening algorithms to more precisely indicate who needs to be evaluated with HRA and treated for these premalignant lesions, and larger scale training programs. And then can we extrapolate the results of ANCHOR to other groups, such as those with immune suppression or women who've had a history of HPV-associated cancer? I would say we can. I don't think there's going to be a repeat study, but probably there does need to be some work to understand how effective some of the treatments are in this group. So just to give you a flavor of some of the screenings, EANS has its own set of guidelines. And what I like about this, it's very flexible. You can screen with one test, and then because the screening tests are so often positive, there's a triage test to tell you more precisely who should be referred to treatment. And so they have options for all of this. And then guidelines for what to do when these results are positive. And the other thing that's really helpful for areas that don't have much access to HRA, but some access, it really helps you to prioritize which groups to focus on, to focus your HRA resources. So it really, instead of the blanket or idea of sending everybody to HRA with an abnormal test, it really helps you to focus on those where the HRA and the treatment of HSIL is likely to make the largest impact. There's also guidelines from the CDC, and then they start with the question of whether HRA is actually available or not. In many places, it's not. And if it's not, it's really focused on digital rectal exams. When it is available, it does give you various options for screening and triage and treatment. So here's one example. So if you're just using cytology, if it's normal, then you repeat in a year. If the cytology is abnormal, then you go to HRA. If you have access to HPV testing, which is quite helpful, then it gives you various options depending on your cytology result and your HPV test result. So just a reminder, digital rectal exams should be part of the standard practice. So the main reason for this is that if you can diagnose anal cancer at an earlier stage, the survival is much higher. So there is some data that even very small cancers can be identified on digital rectal exam. So it is actually a mini procedure, but there's a YouTube video here that can give instructions about how to do it in a systematic way to really potentially find early cancers. So just a bit about HPV vaccination. So a major thing that in treating people is just, we know that younger people should be vaccinated, but what do we do with people that are above the age of 26? Like, who should actually be vaccinated? So there's some limited data in a very specific subset. So this was the basis for an indication up to age 45. This is a study out of Colombia with women aged 24 to 45 with no history of cervical disease or genital warts. And then looked at the efficacy in that group, and it was efficacious. So this was a very specific subset of people that were really not highly exposed to HPV, but doesn't generally apply to most adults. So the current recommendation are 2 doses of HPV if you can start before age 15. The target age is 11 to 12, but I think one major strategy is to vaccinate as early as possible, down to age 9, to really get everybody vaccinated. This is where all the vast majority of benefit comes from. When we talk about vaccination of older individuals, and especially those over 27, that's not where we're going to have our big public health impact. It's really that early vaccination. Oops. Okay. And then the mass, just to get some numbers to it, the mass vaccination of those age 30 to 45 is very expensive and really not attractive from a cost effectiveness point of view. So some new data on anal cancer prevention. This was the original study that Merck did quite a long time ago that showed in young men who have sex with men that were basically early in their sexual history, the vaccination prevented vaccine-related dysplasia, vaccine type-related dysplasia, as well as actual HPV infections. What is newer is there was a study that looked at a longer duration of follow-up, up to 5 or 6 years later, and looked at people who had been vaccinated early, and then also the people that were originally had received placebo and then received vaccination. And what they found was that in those that received vaccine early, there were no vaccine type related warts, dysplasia, or cancer seen. So really the benefit persisted for a long duration. It's really an incredible part about HPV vaccination that if done, prior to being infected with these types, you really see benefit that lasts for years and years and years. And so population level data, this is looking at in Scandinavia, comparing the rates of anal cancer in those that were vaccinated in early age, vaccinated at a later age, or not vaccinated. And really, it was the vaccination at younger ages where you saw almost the elimination of any anal cancer as compared to those that were vaccinated either later or not at all. And then for oropharyngeal cancer, we have limited data on whether the vaccine prevents oropharyngeal cancer. So we have no data on actual cancer, but we do have data on prevention of oral HPV infection. So there are 2 studies. One, a study that I led with the ACTG that looked at the quadrivalent vaccine. In a secondary outcome, we looked at the number of persistent vaccine-related infections in those that had received the vaccine versus placebo. We did see a significance, but a huge confidence interval. So some supportive data, but not definitive. The other data was a Costa Rican vaccine study. They did not look at HPV along the way, but they looked for oral HPV as women exited the study. And what they found at the end of the study was that those that had received not placebo, but a hepatitis A vaccine, 15 of those women had vaccine type oral infections, whereas there was only 1 in those that had received the HPV vaccine. So a very different prevalence at the end of the study. So there are 2 ongoing studies of HPV vaccination that will shed light on this. One study is being conducted by Merck, about 6,000 men around the world, aged, I think it was 26 and older. Half of them received the 9-valent HPV vaccine, half of them received placebo, and we're looking for persistent HPV infections over time. There's a study that I'm leading, funded by the NCI, that's looking at men living with HIV in Brazil, Mexico, and Puerto Rico. And again, we vaccinated men or placebo, and we're waiting, or men received vaccine or placebo, and we're waiting for those cases to roll in. NIH funded with foreign subawards. You can fill in the challenges that await us at the end of this grant year, but we're trying to find a way to get this study completed. Just a couple other words. Single dose vaccination, really exciting stuff. This was a study done in sub-Saharan Africa where they looked at people either got a single dose of a 9-valent or a bivalent as compared to a control vaccine that was not HPV targeted. And you can see that there were really high efficacy rates for either the 9-valent versus the control vaccine, or for the 9 or bivalent for type 16 and 18 specifically. So this is incredibly exciting. The idea that you could give a single dose of the vaccine in the targeted vaccine age and really get long-term protection. So we really, I think one of the major emphasis will be to get longer-term data to make sure that this benefit persists. But this would be a huge game changer, or is already a huge game changer, as many countries have adopted this. And hopefully that will allow them to dramatically expand their vaccine program, so we'll get a much bigger impact. But we need to be wary and mindful of what are the long-term effects of or long-term efficacy of this strategy. And so those studies are ongoing. So next in vaccination, we're moving to 2 and single dose series, maybe in people with HIV. Would that be expected to work? Currently, I think we support 2 and 3 dose series for people with HIV. Ideally, there'll be additional vaccines, perhaps even broader, more vaccine types included, and other vaccine platforms can be considered. So in conclusion, HPV extraordinarily common. People with HIV have higher rates of cervical, anal, and oropharyngeal cancer compared to the general population. In many areas of the world, oropharyngeal cancer rates are rising, and oropharyngeal cancer in the US is more common than cervical cancer. We know that anal cancer and cervical cancer are preventable, and so we do have screening guidelines, but we do understand that access to HRA and anal cancer screening is a challenge. And oropharyngeal cancer, really, HPV vaccinations are best bet for preventing oropharyngeal cancer. Hopefully all of you are HPV vaccine advocates, and really they're most effective when given prior to sexual activity, and really, hopefully we're all champions for that really major public health intervention. So lots of acknowledgements, especially Grant Ellsworth, who is also has worked hard and helped develop a lot of these slides as well, but a lot of my HPV collaborators. Great, thank you.
Thanks, Tim. That was really, really fantastic. It is so confusing right now, and as you know, the currently available guidelines are not the most interpretable, and so it's really great to hear you think through it. We do have a couple of questions in the chat that I think having somebody who's thought so carefully about this gives us a unique opportunity to hear you wax poetic on these difficult topics. So apologies for sort of the broad questions here.
Sure.
So could you talk a little bit about how you approach somebody with visible anal warts? If HRA is available, if it's not available, what's your workup?
Well, it's always good to have a established referral pathway and someone you can refer to who will do the treatment that you would like. That's half the battle. For all of the technique I talked about for treating anal precancers can be used for warts. And so for warts, it's really just about, it's all visual. Like you can do a couple biopsies to make sure there's nothing unexpected, but really it's just about kind of finding the areas and cauterizing them. If there's extensive warts, you can try some topical therapies as well. The CDC OI guidelines has some different options for warts, but it can be stigmatizing, affects, sexual health. So definitely worthy of getting treated. And in addition, it can be hard to diagnose precancers if there's extensive warts. So a lot of clinicians will try to treat the warts and get rid of them and then be able to more fully evaluate whether someone needs additional treatments for anal cancer screening. Sorry, I have my motion activated light. I haven't been able to fix in my office, so I have to wave my arm every now and then. Okay.
No, that's great. Question, do you have motion activated lights when you were in New York also? Or is that a San Diego phenomenon?
No, this is a San Diego thing, and I haven't been able to fix it yet.
Okay, excellent. Do you have a top age at which you recommend ceasing screening for anal cancer in MSM with HIV?
I think that's a great question. I think a lot of it really has to do with how the overall health of the individual. So as we know, people aging with HIV can age very differently. So there's very sexually active, vibrant 75-year-olds that are acquiring STIs, yes, that seems like a reasonable person to screen. But people who are not sexually active, have not had HSIL in the past, perhaps that's not something you would want to prioritize. So I don't think there's a hard and fast rule. I would say like above 80, I don't know of people screening at that point, but above 65, I think it would be individualized.
No, that's really great. Could you talk a little bit about what you consider adequate training in the process of HRA to be qualified and certified? Because as you know quite well, and I'm sure many on the call do, on this Zoom do, is right, Anchor to get those rigorous outcomes used a not generalizable training platform for providers. And so,
Yeah.
with the dearth of available providers, how do you train people? Because right, the lack of access is a big issue in being able to implement this stuff.
Yeah, I mean, I think it's basically someone who's committed, getting people who are committed to this, and there's lots of reasons why it's a great skill set to have as far as like clinical activities, because basically most communities there's not a lot of people doing, so it's kind of white open space for you to build a new practice if that's of your interest. So basically it's a didactic phase where you get the online training where you're seeing lots of images, learning the theory behind it, becoming more comfortable recognizing disease. And then it's really the practice of doing it, which if you have an HRA provider who's trained and proficient, that is really helpful, but some people have to do it without that. And so it's really just slowly doing the procedures, starting maybe without biopsies, but just recognizing lesions and then adding in biopsies. And then over time, once you're able to diagnose disease well, to add in treatment. And so really it's about 50 to 100 HRA cases before you can become proficient. And so one key thing is to keep logs of your case. What was the screening test? How many biopsies you did? What was the result? And then there's really emerging standards for how often you should be finding disease. So it can give you a benchmark if you're doing well. And then there are opportunities, and we have the technology for people to remote in. So if you have video capacity and somebody can remote in and watch your techniques. You can always work with your AIDS education training centers. Many of them do have some HRA capacity, and perhaps through that funding mechanism could support preceptorships, and that would be helpful as well.
And when those training centers no longer have funding, we'll just call you.
Yes. Yes.
Excellent. That's great. Could often there's chatter about the role of HPV vaccination to assist with regression of existing HPV-related disease. Discuss.
So I think regression it doesn't do. I think what it may do is that if you have a treatment, it may prevent or help prevent recurrence of disease. I would say there's really not any definitive evidence now. We have a study in the AIDS Malignancy Consortium focused on women with HPV, many of whom have cervical precancer, where we'll get some more definitive answers. There's been some suggestion recurrent respiratory papillomatosis, like an HPV-associated upper respiratory, so that may help somewhat. But we really don't have great evidence for that. The thing that I'm personally excited about, there are some, I don't want to call it a therapeutic vaccine because vaccine is sort of a naughty word, but an HPV immunotherapeutic. So immune therapies that are targeting people with HPV-associated disease. And there seems to be some evidence in the setting of recurrent head and neck cancer, a very specific HPV-associated condition. But ideally, there would be some additive immune therapies that we could use that are targeted against a person's specific HPV type that would help to clear this disease.
No, that's very exciting. We'll look forward to that. All right. Well, we're out of time, but Tim, thank you so much.
Yes,
that was really
thanks,
fantastic. Great to see you, and thanks for doing that.